Hi, and welcome to the American Society of Echo E3 lecture series. My name is Lucy Safi, and I'm Director of Interventional Echo at Hackensack University Medical Center and Chair of the ASE Emerging Echo Enthusiasts, also known as E3 Special Interest Group. This special interest group provides an opportunity for early career physicians, sonographers, and trainees who are interested in echocardiography to present, interact, and discuss echocardiographic topics. Each lecture is formatted as a 30-minute didactic lecture followed by a panel discussion. On our panel will be 2 moderators and an expert in the field. During the discussion section, the panelists will also answer audience questions, so please enter your questions in the Q&A box below. This virtual lecture series will be recorded and later available online via the ASE E3 website. Today's topic will be assessment of mitral stenosis. It is my pleasure to introduce my co-moderator, Dr. Sangeeta Shah. Dr. Shah is a cardiologist with additional training in adult congenital heart disease who joins us today from VCU Health. Dr. Shah has authored several articles for adult congenital heart disease and has lobbied on Capitol Hill to be an advocate for the appropriate care of adults living with congenital heart disease. She is a fellow of the American College of Cardiology, American Society of Echocardiography, and a graduate from the first cohort of the ASE Leadership Academy. Welcome, Dr. Shah. It's a pleasure to have you with us today. Our expert today is Dr. Ritu Thamman. Dr. Thamman is Assistant Clinical Professor of Medicine at the University of Pittsburgh School of Medicine, Fellow of the American College of Cardiology and American Society of Echocardiography, where she also serves on the board of directors. Her research focuses on cardiovascular disease in women, mitral valve prolapse, mitral annular disjunction, and innovative implementation tools for cardiovascular disease. She is participating in multiple national and international society guidelines and position statements, and is a national and international figure for social media and advocacy and education for cardiologists. It is a privilege to have you with us, Dr. Thamman. Our speaker today is Dr. Mohammed Makkiya. He is a general cardiology and advanced imaging fellow at Montefiore Medical Center, Albert Einstein College of Medicine. His primary interests include multimodality imaging with research focused on valvular heart disease and echocardiography innovation. Dr. Makkiya was awarded the Leo Davidoff Society Award for Outstanding Achievement in Teaching Medical Students from Albert Einstein Medical College. Welcome, Dr. Makkiya. We look forward to your presentation.
Thank you very much, Lucy, for the nice introduction. Hi, good evening, everybody. My name is Mohammed Makkiya. I'm a general cardiology and advanced imaging fellow from Montefiore in the Bronx, New York. And welcome to another E3 lecture series. And today we're going to talk about mitral stenosis. I have no disclosures. So the outline of my talk is going to be about the possible causes of mitral stenosis. We're going to venture on about quantification of the severity, application of exercise testing and evaluation, and lastly, we'll finish with management. So causes of mitral stenosis, the most common cause is rheumatic fever, then followed by extensive mitral annular calcification or MAC, and then what less common causes including congenital disease or obstruction of the left ventricular inflow by an LA mass like a myxoma, thrombus, or endocarditis. So rheumatic fever or mitral stenosis is the most frequent valvular complication of rheumatic fever. Even in the industrialized countries, most cases remain of rheumatic origin, as other causes are rare. There is typically doming of the anterior mitral valve leaflet, that is concavity of the anterior mitral valve leaflet toward the left atrium in diastole. Some people also call it the hockey stick sign. There is also thickening of the valves that starts at the leaflet tips and extends to the mid-portion body as the disease progresses. And there is also posterior leaflet motion restriction. The main mechanism of mitral stenosis is commissural fusion, which causes the doming, which we can see in the peristernal long axis view of the mitral valve. Both commissure fusion and circumferential thickening of the valve results in limiting the opening of the valve in the medial and lateral dimension. Thus, the valve mainly opens predominantly in the anterior and posterior dimension, giving it a characteristic fish mouth appearance. This is better seen with 3D echo. There is also associated thickening of and shortening of the subvalvular apparatus, and especially the chordae. Here is an M mode of a normal mitral valve versus a rheumatic valve. On the left side, what we see an M mode of a normal valve, when you can see the anterior valve leaflet and the posterior valve leaflet open nicely. There is the E, F, and A slopes. While on the right-hand side or picture, we can see clearly that the F slope in rheumatic disease or mitral stenosis, the F slope is prolonged and there is almost absence of the A. And we can see here the posterior valve is basically the motion is restricted and is not opening that much. This is a gross appearance or representation of the mitral stenosis, where we can see thickening of the valve leaflets and fusion of the commissures, and there is the thickening of the subvalvular apparatus. Now, another cause of mitral valve disease, which now we are getting to focus more about, is mitral valve annular calcification. The main lesion is annual calcification. It is frequently observed in the elderly, people who have chronic or end-stage renal disease, people with hypertension and atherosclerotic disease. However, because the annulus is too large to begin with, the calcification of the mitral annulus has few or no hemodynamic consequences and causes mostly mitral regurgitation rather than stenosis. However, some patient may have extensive annular calcification, like this case that we have here, that extends all the way to the leaflet bodies, sparing only the leaflet tip, and may result in significant stenosis. As we see in here in these images for the same patient, the patient has elevated mitral gradient from MAC, which measured around 8 to 9 millimeter mercury, and patient was symptomatic. We should keep in mind that balloon valvuloplasty does not work or not done on these patients, as balloon valvuloplasty mostly by disrupting the commissural fusion, and commissural fusion is not the issue here of the calcified non-rheumatic mitral valve disease. Thus, valvuloplasty does not work, and it may result in annular splitting, which is a bad consequence. Now we talk about other non-common causes of mitral stenosis, like a congenital disease, which is parachute mitral valve, as we see in these echo 2D pictures, which is characterized by anterior and posterior leaflet chordae arising from a single papillary muscle, causing functional stenosis, mainly from the trabecular network formed by the chordae, and also leaflet, the anterior leaflet motion restriction kind of bunched to one side, restricting the motion, resulting in functional stenosis. And less common cause, other causes for mitral stenosis, which is functional from obstruction of the LV inflow by LA mass, as we can have here, as we see here in a case of atrial myxoma. Now, we're gonna talk about the quantification of the severity of mitral stenosis. We have many echo tools that can help us and guide us in quantification of the severity of mitral stenosis by measuring the mitral valve area by direct planimetry, pressure half-time method, continuity equation, and area by PISA method, and finally by gradients across the valve. So planimetry measurement is obtained by direct tracing, as we can see here, of the mitral orifice, including the open commissures on the parasternal short axis view, usually best measured at mid-diastole in the cardiac cycle. Bear in mind that image quality is important here and of paramount importance due to, as we need accurate measurement and tracing. We can improve the image qualities by changing the gain settings and adjusting it to visualize the whole contour of the mitral orifice. And keep in mind that excessive gain may cause underestimation of the valve area, in particular when the leaflet tips and dense and calcified. We can do other things by improving the frequency and resolution, like switching to R mode, decrease the image sector width. Here, like also careful scanning from the apex to the base of the LV is required to ensure that the cross-sectional area is measured at the leaflet tips where it is the smallest and most accurate. Remember, this is important as mitral valve annulus leaflet has a kind of funnel-like appearance. And if our short axis cut is too high, as in the funnel, as in line B here, if we're cutting high up, as in line B, high in the funnel, closer to the LA, it tends to overestimate the valve area and affect our accuracy in measuring planimetry. We can overcome this by using 3D imaging and biplane imaging. Here we have biplane imaging when they are useful in optimizing the positioning of the measurement plane and therefore improve their reproducibility. We can use parasternal long axis view to grade where the leaflet tips are and where the area is smallest, and use the biplane feature to place our cursor on, as we see here in this image, to generate the short axis view, and we can measure the area by direct planimetry on it and trace the area. But this comes on an expense of sacrificing frequency. As we see here, it's 36 Hertz. Thus, the resolution will go down and may make us encounter problems in measuring and tracing. Again, we can overcome this by doing directed parasternal short axis view to improve the frequency. But again, we have to make sure we are at the leaflet tips when we are imaging. As we can see here, the frequency went up to 50, thus the resolution is better by just switching to direct parasternal rather than biplane. Now we can do planimetry using 3D technology. We can process the 3D acquired images like here, retrospectively using different software. This was first developed in 2006 to do planimetry on 3D. We can use different planes to plan the short axis view and choose where the leaflet tips to plan the optimum short axis view to do direct planimetry on. But also we have to keep in mind the limitation of 3D in regard of the spatial resolution, as it has, so far it has lower spatial resolution. And planimetry comes with some limitation. If we have poor image quality, which makes tracing difficult when the cut plane cannot be optimally aligned to the smallest orifice, and in calcified valves when we have a lot of artifacts and dropouts, rendering the tracing difficult. Now we talk about another method to qualify the mitral valve area, which is the pressure half-time. The pressure half-time method is based on the assumption that the rate at which the gradient drops during diastole corresponds to the severity of mitral stenosis. This means that the rate of LA pressure and LV pressure reaches equilibrium in diastole, and the time it takes for the pressure to go down by half is the pressure half-time. In mitral stenosis, it delays this equilibrium and causes the pressure half-time to become longer. Pressure half-time is derived by tracing the slope of deceleration E wave on the continuous wave Doppler tracing of the transmitral flow, as we see here. And the valve area is calculated automatically by the software using the constant 220 over the pressure half-time. Mitral valve area is inversely related to the pressure half time. So if the pressure half time is long, the valve area becomes the smallest. So the steeper the slope is, it means the shorter is the pressure half time, the valve area will be the greatest or the largest. We can apply the pressure half time method in atrial fibrillation when we have varying RR cycle, but we have to use a couple of cardiac cycle and average them. Mitral valve also can be area can be calculated from the deceleration time. As we see here, the deceleration time is the time it takes from the peak velocity to reach zero velocity. The pressure half time is about 29 to 30% of the deceleration time. And using the equation of 750 over the deceleration time, we can calculate the mitral valve area. Benefits or pros of the pressure half time, it's less dependent on the heart rate and flow across the mitral valve, and can be used in varying RR interval, as we mentioned before, and in atrial fibrillation. However, it comes with pitfalls and limitation because it's very dependent on the diastolic compliance of the left atrium and left ventricle. So in case of non-compliant left atrium that is stiff and narrow, the pressure has to drop significantly in order to keep the same stroke volume to the LV. Thus, the pressure half time shortens and the mitral valve area is overestimated. Bear in mind that after balloon valvuloplasty, the pressure half time is not valid to calculate mitral valve area, especially in the first few days due to change in the LA compliance, thus shortening the pressure half time and results in overestimating of the valve area. Sometimes non-compliant left atrium will result in a deceleration slope that is sometimes non-linear bimodal, as we see here. There is a decline of the mitral flow velocity, early decline in early diastole, which is steep, then followed by, then the following part of the E wave becomes slower, or the slope becomes slower. In these cases, where to measure the half time, where to do the slope, where to put it? You put it on the first part or on the second part of the E wave. This was studied by a study by Gonzalez, which he showed that the area calculated by the pressure half time with tracing of the deceleration slope in mid-diastole rather than the early deceleration slope correlates better with planimetry and CAT. Sorry, as we see here. So it's best to trace the slope in this second part of the E wave. Another limitation of the pressure half time when we have atrial septal defect, which results in left to right shunt decompressing the LA and thus decreases the gradient between the left atrium and the left ventricle, shortening the pressure half time and resulting in overestimating of the mitral valve area. Another, similarly, in patient who has significant aortic regurgitation or non-compliant stiff ventricle, the left ventricle LVEDP will increases and result in decreasing the gradient between the LA and LV, leading to decrease the pressure half time and overestimating of the valve area. Other limitation at very high heart rates, sometimes we see the mid-diastolic flow, as we see here in this picture, is greater than the early diastolic flow, and we are unable to trace the slope and thus to do the pressure half time. Also, the pressure half time we cannot apply it in calcified valve as it's unreliable. Now we switch gears to another way of calculating the mitral valve area, which is the continuity equation, which simply flow in equal to flow out. The continuity equation is based on the law of conservation of mass, and it assumes that the volume of blood through the mitral annulus should be equal to flow across the mitral orifice. It assumes there is a uniform velocity at the annular or subvalvular level, as in the aortic valve area evaluation. However, this is important. This is not true in the mitral valve annulus, as there are different range of velocities going toward the orifice. So that for that reason, we apply the continuity equation by using the forward flow calculated across another valve, mainly the aortic valve or the pulmonic valve, mainly the aortic valve, as the stroke volume from the pulmonic valve calculation by echo is limited due to limited acoustic windows and difficulty in accurate measurements of the RVOT diameter. Continuity equation has its own limitation, as we are substituting the forward flow across a different valve, aortic or pulmonic. Continuity equation cannot be applied in significant or moderate aortic regurgitation and mitral regurgitation due to the difference in the forward flow between the two. It's also limited in atrial fibrillation, the presence of shunts, and we are more prone to errors as we are doing too many measurements. So any problem in acquiring the velocity or any error in measurement can lead to inaccuracy in calculating the mitral valve area. And finally, we can calculate the area by the PISA method, the proximal isovelocity surface area, which follows the same principle that area equals flow rate over velocity. The application here similar to what we use when we calculate the mitral valve regurgitant orifice area. However, here we do it in diastole. PISA method uses the aliasing velocity of the mitral inflow to calculate the mitral flow volume, which is divided by the peak velocity of the diastolic mitral inflow to derive the mitral valve orifice area. So peak flow equal 2 pi r squared. The r is the radius of the PISA. VA is the aliasing velocity that we set, and we have to correct to the angle to get more accurate measurements. And mitral valve area equals to the peak flow divided by the peak velocity from the continuous wave Doppler of the transmitral flow. The PISA method can be used in the presence of significant MR. However, has the following limitation. It is technically demanding and require multiple measurements. There are uncertainty in measuring the radius, which reduces the accuracy as we are going to square it. That's multiplying like the error. And there is uncertainty in opening angle measurements. And we are assuming that the PISA have a hemispheric geometry. In most cases, it's not the case. It may have some elliptical geometry rather than hemispheric, and we have to use a different equation for that. Now we switch gears to the pressure gradients that they come from the cath world. Rick Nishimura did this magnificent study, compared in his study, as we see here, the accuracy of Doppler-derived echocardiography gradients with that the conventional left cardiac catheterization gradients in patients with MS. He showed that Doppler-derived gradient is more accurate than the gradient derived by conventional cath, as we see here, versus the one derived by the conventional cath by wedge pressure and LV pressures, compared to the direct pressure measurement of pressures in the LA and LV, which is the gold standard. Tracing the velocities of mitral stenosis from continuous wave Doppler allow the calculation of mean gradients based on the mean velocity of the tracing. The velocity and they're converted to pressure gradient by using the simplified Bernoulli equation for V squared. Mean gradient is hemodynamically more relevant than the peak gradients because the peak gradients or maximum gradients depends on the LA compliance, LB diastolic function, and associated MR. Mean pressure gradients is important in prognosis and evaluating mitral valve after balloon valvuloplasty. We have to acquire the images accurately, and so we can do accurate tracing. And this should be done in an apical window in most cases, as it allows to parallel alignment of the ultrasound beam with the flow, with the mitral inflow. And we have to make sure we have good optimization of the gain settings, beam orientation, acoustic windows to obtain well-defined contour, as we see here in this picture, to trace the Doppler flow. And we have to trace in all diastole, even if the velocities reaches 0 before and the end of diastole, and we have to always report the heart rate. The pressure gradient limitations, or especially the mean gradient, is dependent on factors that influence the transmitral flow rate. The most important being the heart rate, cardiac output, and associated MR. Mean gradients are usually higher at a high heart rate and at mitral regurgitation. So in these cases, we should interpret the results with caution and use other parameters in making the diagnosis. Also, when we are doing an echo on a mitral stenosis case, we have to look and report other associated findings of MS. One of them is left atrial size and dimension, and if there is an enlargement, because some studies showed that left atrial size less than 5 centimeters predicts better procedural success after balloon valvuloplasty. We also have to report if there is a left atrial or left atrial appendix thrombus. You don't want to give the patient stroke. If there is any intraatrial septal defect or aneurysm, as this will render the transseptal defect difficult. And this slide, I'm sorry, it's very busy. It comes from the ACC/AHA guidelines that came out last year. Just to summarize the classification or stages of MS, basically severe is considered when the mitral valve area equal or less than 1.5 centimeters square, with the pressure half time more than 150 millisecond. Now exercise echo and mitral stenosis, when we do that. So exercise echo is usually useful in patients who have discrepancy between the clinical symptoms and the resting hemodynamics measured by resting echo. Like people who have shortness of breath or dyspnea on exertion. However, their resting parameters are not consistent with severe MS. Or another example, like patient who has mitral valve area by echoes less than 1.5 centimeter, but they claim to be asymptomatic. In these scenarios, it's best to send them to do an exercise test with the measuring of the mean mitral gradient and pulmonary artery systolic pressure. Preferably, we use semi-supine exercise echo rather than post-exercise echo, but both works. But the advantage of the semi-supine echo is it allows for monitoring of the gradient and pulmonary pressure at each step as we are increasing the exercise workload. Patient who has increased gradients more than 15 millimeter mercury or have increased pulmonary artery systolic pressure with exercise have to shown to improve symptomatically after balloon valvuloplasty. As we see this patient here, at rest, his heart rate was 60, his mean gradient was 7 in the top part, and the pulmonary artery systolic pressure is 30 millimeter mercury. After putting him on the bike and exercise him, his heart rate went to 120, his mean gradient measured up to 24 millimeter mercury, and his pulmonary artery systolic pressure was 62. Now, management. So symptomatic patients with clinically significant mitral stenosis are candidates for either mitral valve replacement or balloon valvuloplasty. Echo plays an important role not only in determining whether the stenotic valve is suitable for valvuloplasty, but also in monitoring the procedure during the intervention and determine the effects of valvuloplasty. Good immediate results after valvuloplasty can be obtained if we choose the patient right, more than 80% of the patient. And here's the slide of the AHA-ACC guideline from 2020 about valve intervention for MS, which is roughly summarized that the patient with severe MS with pliable valve and no significant MR should get a balloon valvuloplasty class 1A indication. Now, as far as the calcific mitral valve disease, a lot of debates going on, and basically patients who are symptomatics and have significant mitral stenosis who are good for surgery or transcatheter replacement, if they meet the criteria, can undergo intervention if they are symptomatic. Now, how can we evaluate if the valve is pliable? Is by doing the Wilkin score. The Wilkin score is based on a morphological criteria grading of the mitral valve apparatus, which is based on the leaflet mobility, leaflet thickening, leaflet calcification, and subvalvular thickening. Importantly, it does not include subvalvular calcification. Here are the scoring for each of the leaflet mobility and valvular thickening, which is mostly of the anterior mitral valve. And based on the score, we get a total. The total is 16. Wilkin scores of less than 8 predicts favorable results of percutaneous balloon valvuloplasty. More than 12 is usually bad. 8 to 12 is a gray zone. Here is an example. Let's see if I can play this, of a patient who has mitral stenosis that we have at our facility. Stroke, sorry, I didn't. That you see the mobility of the is reduced of the valve. There is a pronounced leaflet thickening at the proximal mid portion of the valve, and there is extending calcification to the mid portion of the leaflet, and the subvalvular apparatus is heavily thickened, causing him to have a high Wilkin score, and that's not a good candidate for balloon valvuloplasty. On the other hand, here we have a patient also with the mitral stenosis who has good leaflet mobility and mild thickening with minimal calcification and subvalvular thickening, giving it Wilkin score less than 8. That's favorable for balloon valvuloplasty. And there are other criteria in patients that exclude them for balloon valvuloplasty is patients who have more than mild mitral regurgitation, that is moderate to severe, patient who has severe tricuspid regurgitation because it does not work, and these patients may benefit from surgery which permits additional annuloplasty of the tricuspid valve. If there is a left atrial thrombus, you don't want to give a stroke, and in calcified MS, as we mentioned earlier. And the best way to do a successful balloon valvuloplasty is to split open the commissures, as this one's seen in this study. We have to crack open both commissures as an MHD so we can get the best results of balloon valvuloplasty. So in summary, transthoracic echo is the single most important diagnostic tool in the evaluation of mitral stenosis in day-to-day practice. It helps in establishing the diagnosis, assessing the severity, and plan for successful intervention. Transesophageal echo is recommended only when the thoracic approach is of poor quality and to detect left atrial thrombosis before balloon mitral valvuloplasty. And with that, I conclude my presentation. Thank you very much for listening, and I give it to the moderators and Dr. Thamman to start the discussion. Thank you.
Thank you so much, Dr. Makkiya, for that excellent presentation. I encourage all to input any questions that you may have in the question and answer box at the bottom of your screen, and they will be addressed. We did get a question about how to join the ASE 3, and the way to do that is to log on to your ASE account and then click on Update Your Profile. Click on Specialty Interest Group and then look for ASE E3. All the specialty interest groups will be listed there. So thank you so much for your great presentation. I wanted to ask Dr. Thamman the first question, and this is one of the questions that I've been thinking a lot about. You know, calcific mitral disease is so prominent. And often in the real world, what we encounter is a very densely calcified mitral valve annulus. And, you know, perhaps the sonographer didn't have a transthoracic 3D probe or didn't have the time to get, you know, the 3D images. But how do you report, you know, calcific mitral stenosis if all you really have is transmitral gradient and maybe a pressure half time? You know, what is your technique on reporting that?
I think that's an excellent question, and it comes up all the time because we do not have prospective data yet on this. Of course, it's such an emerging and growing entity in the first world. Wealthy nations are seeing much more of this. And in Catherine Otto's update and ACC/AHA guidelines for the management of valvular heart disease, there's just a mention of this calcific mitral stenosis, and she writes that that really it's very difficult to determine the extent of the severity because you just can't see from the amount of calcification. And that the degree, the progression of calcific amount of mitral stenosis is so variable. It can be less than 1 millimeter of mercury to over 9 millimeters of mercury. And I think that's what we're using more than other parameters because of all the shadowing with the calcium. So if you have, and generally the prognosis is so poor, like this 5-year survival is less than 50% when we have such patients coming in. So if they are, you know, a good elderly person who may be coming in for yearly echo for even other valvular conditions, which are much associated with this, and you see that, you know, their gradient just, the pressure gradient went up significantly, not just less than, you know, stay the same, then and if they're symptomatic, and it's kind of hard to tease out. And I think that people are using exercise stress echo, but not as much as say in the Mayo Clinic, where you know everyone is evaluated in that way. So you can either do that, do it if they're capable of getting on a bike and supine bike and doing that and seeing how fast that they're progressing, and ideally get them in a study because we don't have any real good data to say one way or another. So ideally, you know, you're in a center, probably have studies going. Most mitral valve centers have, you know, clinical trials ongoing with these various devices. I mean, these devices now are like flavors of ice cream, you know, pick your flavor. So you'll have lots of choices.
Thank you so much. Actually, we did get a question about doing stress tests for mitral stenosis, and they asked, how do you adjust for the heart rate? Does anyone on the panel do stress tests for mitral stenosis routinely that they can kind of elaborate on that question?
Well, we always report heart rate when you're reporting mitral stenosis, because of course the gradient is going to be affected by that. And according to Patty Pellica, who wrote the ASE stress echo guidelines, you know, there is a range that you have to just qualify that with the heart rate. And of course, you're looking at all other parameters as well. You're looking to see if the pulmonary hypertension, or, you know, did the patient develop pulmonary hypertension? Did the RV dilate? Did the RV, does it look a little bit down? So those are other ways of assessing, along with, you know, what is going on with outside of the heart rate affecting the gradients.
There's another question that's been posed, is which is the best method to assess calcific MS, which is kind of what Lucy asked, but maybe to tell us, what would you put in a report? So we're seeing the patient in 2020, we're going to see them in 2025, so that we can help that patient. I think one of the things that I noticed is that all those aortic stenosis patients that we screened for TAVR had mitral stenosis. So what are how would we methodically show the parameters? Should we be giving mean gradients with the heart rate? Should we be putting in the reports pressure half time? What is something that we can follow, in your opinion, so that when we look at it 5 years from now, we have parameters to kind of compare to, since it's so hard?
Yeah, and I think that's an excellent question. I think, like you say, these patients already coming in with, say, aortic stenosis for TAVRs, they're already having concomitant diseases, maybe even atherosclerosis elsewhere. And so many of them are getting these tests, and some of them are getting CTs. And the CTs, actually, you can see the calcium and that whole, in fact, there's a really nice study where you can see on CT and the calcium. And so these patients who are coming in, you may just be doing this for other reasons as well. And I think that becomes a little bit easier to see and to quantitate, if you will, and see the progression over time. I think it's a little bit easier than just looking at a transthoracic because of all the shadowing that is involved. Sometimes they're ending up getting a 3D TE, which again, you know, the image quality is superb, and but we don't have a systematic way of quantitating this. And I think that's a real important concern. And I think going forward, as we, you know, there is so much of this data, it's just say in the last year, even the last 6 months, you know, that's coming, and we need to have sort of a national registry that we can prospectively look and say, wow, this, you know, and use some maybe modeling to see what parameters, what factors are actually leading to that. We know for MAC, you know, it's female sex, it's, you know, the elderly, renal failure. Are they the same things that, again, are causing progression in these patients that are coming? I mean, we know to a certain degree, those are the risk factors, but is there something else on imaging that we are not seeing right now, the pattern emerge, other than the gradient, you know, the pressure gradient went up by 5 millimeters of mercury versus 1 in this year. But even if we could follow that, so I think that's how we should try to report it. But I think all of us coming together and just the fact that we're discussing this, and at the ACC also in a couple of weeks, a lot of discussion around this point suggests that we're ready to really delve in. And I know that Maura at Mayo Clinic has, developed a MAC a score, but it's not a prospectively developed one, and it's small numbers. But she's the only person I know that has that score that she published last year. And that was really to see only in the context of seeing whether a device would actually, if she inserted the device, would it actually stay or move? And that was the reason behind it. But this is a different kind of question that we're asking, or that you're asking. And it's a very important one. It's a huge part of our population.
Yeah, absolutely. And especially as these percutaneous interventions continue to evolve, I'm sure they're going to expand into the percutaneous into MAC kind of procedures. So there was an excellent question that came through about stroke volume. Should we really be reporting stroke volume instead of mean gradients? What are your thoughts on that?
I will just say that in the COAP study, for example, the original guide, the original method section had, calculate the stroke volume. But when they actually had gathered the data from labs all over the country, they had to eliminate a third of the data sets because they were inaccurate. In fact, J.O. wrote an editorial in the New England Journal saying, you can't have a stroke volume of minus 15 cc's, right? So those stroke volumes then subsequently were thrown out by Frederico Ash. And so going forward, there is no stroke volume calculations because it is fraught with so many problems, because it's very hard to measure correctly, and then you're squaring measurements and the errors get squared, and you're magnifying the error. So we're not routinely reporting that. Now, you might be doing LV EF by 3D, and we are trying to do that as much as possible. And if you're using contrast, even better. But again, there are no ASE guidelines on numbers for contrast. And we know that they're going to be slightly bigger, but they end up both, the diastolic and systolic are a little bit bigger. So overall, the numbers stay the same. But still, we'd like to have that going forward as much. So I don't know if I answered the question, but.
No, you did, definitely. Yeah, you definitely did. I find that question very intriguing to me because, what happens also when you have obstruction in series. So, mitral stenosis, aortic stenosis, we're always trained to treat the AS first, but, are we really underestimating that MS? And then what happens afterwards? What are your thoughts on MS and concomitant AS? It's difficult to measure. How do you truly measure it?
Yeah, I don't have a good answer for that, but I think that this is, again, data that needs to come forth, like in those patients that are presenting with AS and we're treating the AS. Only now, I say in the last several years, we're becoming aware that, wow, they also have this amount of calcific mitral stenosis, which we really don't know. But if we go back and look at the images, I'm sure we could glean, much clearer answer, even if it would be retrospective in nature. So, but I think it would be really great. So now, say somebody comes in for a TAVR, there should also be on that report, what was the status of the mitral valve? What was the heart rate? What was the mean gradient? What was the amount of calcification? Or like, where was it located? Because if they progress from MAC to CMAC, which is, caseous necrosis of that calcific area, that has a different prognosis and it's worse. And we'd really like to know that, and perhaps that would also impact, our choice in, taking a patient for TAVR or not.
Mm-hmm. No, absolutely. Dr. Shah, I think your lab did some work on developing an index score for mitral stenosis. Can you talk a little bit about that?
Yeah. So Dr. Kim Rudin and Aktay were the spearheaders of this research that they did, and kind of, what do you do? How do you, there's so many variables. I mean, when he presented, right, this parameter is confounded by if you have MR, this factor is confounded if you have this. And so your brain eventually goes, okay, so what do I use? And even heart rate changes and your mean gradient changes. So what the two of them did is they started to look at dimensional index. And so they found about 64 patients, 24 were rheumatic, the rest were calcific, and they did continuity equation on all the valves, and then looked at the pulse wave LV outflow tract VTI and compared it to the continuous wave VTI through the mitral valve. And what they showed in this small study is that in the degenerative calcified mitral stenosis, a DVI of less than 0.35 was significant for a valve area by continuity equation of less than 1 or equal to 1. So something like, you just as a lab need to keep reporting something consistently, whether it's 5 parameters, 2 parameters, what you do with the help of your sonographers, and really decide on then retrospectively learning. And just like you said, is really, I mean, the amount of research that can be done and that needs to be done on this forefront is amazing and interesting. So we'll see if it evolve just like we saw aortic stenosis evolve over a few years.
Yeah, absolutely. So a quick, a reliable, and a reproducible measurement is something that we are looking for sure in the mitral valve area, and especially post-procedural, when we're doing a valvoplasty on a patient with rheumatic heart disease, and you have about 2 seconds to answer, what is the gradient and what is the MVA? You need something quick and reliable. And, going just back to valvoplasties for rheumatics, do you find, or do you think in your lab, is it better to do those procedures under TEE, where you can really get a quick and easy assessment of the residual MR, or do you think doing it under T will change the intracardiac pressures and affect the data? Do you favor transthoracic then? So what are your thoughts on that?
I think you definitely need to do 3D because you need to make sure you're actually opening up the commissure, cracking the commissure, and not tearing the leaflet. And that you need 3D for that. And there's good data for that. And of course, your hemodynamics will be, shifted because you're giving them medications, but you do need to see that detail. So if you're, doing the valvuloplasty, you stop if you're, you see the tear. There was one other question that somebody's asking about, do you have to planimeter, let's see, 3D echo for planimetry. Planimetry, if you're doing 2D, you need to make sure then you can take an orthogonal view if you're doing just 2D. But because when you measure at the tips, that should be equivalent to what you're getting on your short axis. If it's not, then you're not measuring the greatest diameter, and you have to make sure that the cut plane is perpendicular. And as you can see here, sometimes, if you slice here, you're going to get a larger one than if you slice right at the orifice where it's completely narrowed. And anatomic measurements are not the same as hemodynamics, as was nicely explained. And then the other thing that happens, this was shown by Bob Levine's group many years ago in the 90s, and then Peeborough as well. They looked and saw that when you have streams of blood, flowing and you get to your effective orifice area, it's much smaller than your anatomic orifice area. And what happens is that they were using this coefficient of orifice contraction because the orifice contracts, right, as it goes through this small area. But the geometry of the actual leaflets is also changed. And so what we see in a lot of these domed, it's even smaller. These are the CCs, which is the effective orifice area. So you have different geometry from rheumatic versus tubular shape that is much more seen in calcific. So you do need to do either an orthogonal, or you need to do a 3D view to actually be able to answer the question.
That was excellent. Thank you. And oftentimes I do report the anatomical regurgitant area using 3D and multiplanar reconstruction. And currently, we use the same EROAs to kind of say, greater than, this is severe, or smaller than this is severe. But it's very nice to do 3D on these because, like you said, you can really line it up right at the leaflet tips, and it's very helpful.
I see Enrique's question.
Yep. So Enrique states, fantastic presentation, and congrats to all the speakers. Regarding 3D MVA by Planimetry, he'd caution about resisting the temptation to measure directly on the 3D rendered image. And that's very true. So, to use the multiplanar reconstruction is definitely something that, is recommended, and not directly measuring on the 3D. So thank you, Enrique, for that. That's a fantastic point. And we are actually nearing the hour. So, this hour flew by. Thank you all so much. And, thank you, Dr. Makkiya, for such a wonderful presentation that you gave. I want to again encourage all to, join the ASE, log into your account, and you can join the E3 Special Interest Group by going under Update Your Profile, and it will be listed there. Also, our website will list every lecture. They're, again, every other week on Mondays, so you can stay tuned for the next lecture in 2 weeks. Dr. Thamman, thank you so much for joining us today. Dr. Shah as well. I really appreciate both of you and your time. And thank you all for joining in tonight. Take care.
Thank you.
Thank you.
Yeah.
Thank you, guys.